Hi, everybody. Mike Myers here. I'm the residency director here at UNC, and I look forward to meeting all of you when you interview with us. The last couple of years, as we've moved to a virtual format, I've pre-recorded these comments, and they evolve year to year, of course, depending on changes and evolution in the department and the residency program. But there certainly is a theme, and a lot of the slides look similar. My goal of this is to hopefully give you a little bit of information about the program in the department. Certainly a time of change for us with Dr. Caprice Greenberg joining us as the new chair of the department a couple of months ago. And we look forward to a lot of the interesting goals, including a lot of educational goals that Dr. Greenberg brings to UNC. So I'm going to launch some slides and I'll go through this. I'm going to record this in two parts just so it's not quite as long. And again, as you go along and look at this, please jot down questions. We will build in an hour at the outset of our interview day just for some interaction and questions. Instead of me talking to you for an hour live, I felt like this is something you can do ahead of time just to gain information. So let me grab those slides and launch that. Sorry for taking me a moment. All right, I'll put this in here. And so just let me start off by introducing myself. I have been here for my 20 years. This is my 20th year. I came here in 2003. I came straight out of fellowship, and the question always comes up, why have I stayed and what's kept me here? Like many people, I've had other opportunities, but both personally and professionally, it's been a pretty good place to be a faculty member. It's a very nice place to live, and I'll talk about living here in a little bit more. You'll get better ideas about that from the residents, but it's a nice place to live. It's easy place to live, and I don't face a lot of traffic, and it's been a great place for my kids and my family to be. And then professionally, I've had ongoing opportunities for growth and professional development. I have a great practice, and so for a lot of reasons, I have stayed and have enjoyed being here. I've been the residency director for 10 years. I started in September of 2012. So this would be my 11th year running the residency program. And for similar reasons, I've continued to do that and want to do that. And it's been something that's engaging. I look forward to continue to mentor and grow other faculty who have educational interests and interests in things like running the residency program. We want to have people who want to do those things and have a new blood and new voices involved. And I'll mention a couple of our associate program directors here in a minute. So this is just a brief outline from a residency perspective, or rather from a talk perspective, that I'm going to walk through and talk just a little bit about the history here, the system as a whole, although that doesn't really impact the training program at present, and then background around the leadership of the department, and then spend most of my time talking about the program and a little bit about the area. But again, I think you'll get better information from the residents about that. So this is the oldest public university in the U.S., about 29,000 students. A sizable proportion of those are graduate students, and that includes the medical school. It's one of the top 10 universities in research funding. These are 2021 numbers, over $1 billion in annual research expenditures, approximately $700 million in annual federal funding, and $530-some million in annual NIH funding. And the School of Medicine and the School of Public Health, both of which touch on the Department of Surgery, are sizable parts of that funding. The School of Medicine was founded in 1879. What was then the North Carolina Memorial Hospital was built in 1952, and that's still part of our campus. It's covered up by a lot of other things that have grown up around it. Pretty much all those trees you see in that picture are gone, but the institution certainly has changed in 70 years, as has every other institution. This is the campus looking across from the football stadium, and we border the undergraduate campus. That inset is the original Memorial Hospital, which is not far from where I'm sitting and recording this talk, and it still functions as an administrative building. This is the medical center today, a shot from across the street in the parking garage. The medical center is comprised of separate hospitals that you can see here that all function together as one unit, but separate name, separate in mission and care. Certainly some things are combined. All of our operating rooms are in the same location, whether it's cancer, general surgery, et cetera. But many of the patient services are separate through these buildings. On the left here, and I'm honestly not sure whether the arrow shows up on the recording, but on the screen left is the original Memorial Hospital. And then to the left is going to be our new OR tower, OR and ICU tower, and I'll talk about that a little bit later and show you a couple of pictures of that. The system is a not-for-profit 15 hospital system, 14 hospital, 15 hospital, depending on how you count the system. And some of those are truly part of the system. There are entities that are held within the system. Some are strong affiliations. And if you count those, we are a 15 hospital system. And then we have a really strong educational affiliate in Wake Med Hospital in Raleigh. Wake Med is not part of our healthcare system, but it's an educational affiliate. A number of residency programs have trainees there, including us. Approximately 50 some odd residents are at Wake Med at any given time. And so it's been a long-standing and excellent educational partnership for us in surgery, along with other departments. This is just another picture of the healthcare system. This is coming from the west. Directly in front of the lower part of that picture is the ambulatory center. We have an ambulatory surgery center there that has 8 operating rooms, and you spend time there. This is a little bit of a dated picture. You see construction in the foreground, and that building has been complete for a number of years now. But this just looks across the campus toward the hospitals, and you can see those all in the distance. The health sciences campus is comprised of a number of different entities. We are one of the institutions that counts the School of Medicine, School of Public Health separately. So when you look at funding across campuses and across medical schools, many of them include public health school funding that falls under the School of Medicine, and ours does not. But these are all very collaborative arrangements and across the campus. There has been a long history of strong leadership in the department. You can see the prior chairs here. Dr. Tony Meyer is still a member of the faculty, still operates. And then Dr. Melina Kibbe departed a year ago to become the dean at UVA. Although her tenure was short, she certainly made an impact on the department. And as many of you know, she continues to be a leader in American medicine and certainly in surgery. And then we're ecstatic to have Dr. Caprice Greenberg, who joined us in August. And she spent many years at the University of Wisconsin and then was the prior chair at the Medical College of Georgia in Augusta before coming to UNC. And so we look forward to her leadership, and she has a lot of interesting and exciting things. And I think we'll anticipate her talking a little bit more about that live on the interview day when we join you with some of the other department leadership. We're organized similarly to a lot of other disciplines. We I'm sorry, like a lot of other departments of surgery, we're divided largely by discipline, and this is what this looks like. GI surgery for us encompasses minimally invasive surgery and colorectal surgery. Surgical oncology includes endocrine surgery for us, and pediatric surgery, abdominal transplant. We do have an islet cell transplant program here. Dr. Chirag Desai runs that and started that when he came here a few years ago. And so that has been an avenue for growth for resident education and experience. Not so much for the islet cell part of it, but the operations that go with it, and the pancreatectomy aspect of that. That's been a great addition. And trauma and acute care surgery is a foundational group here in our department and program, and residents work with that group across almost every year of training. Burn is a separate group for us. It's always been a large clinical enterprise, and so that's a separate division for us, and our residents rotate there as PGY 1s and 2s. Then vascular, cardiothoracic, and plastic surgery as the surgical subspecialties. So let me shift gears and talk a little bit about program overview and structure, and just touch on that. So this is our the last group photo we had, which is now a couple of years ago. We will look forward to updating these now that we are able to do more of things in person as we've gotten out from COVID. But the Rogue President's programs are run by a group of us, and Dr. Trista Reed is one of our associate programmers, and Dr. Ariel Perez is another. Dr. Reed is a trauma critical care surgeon. She was a resident here, and then she left for a fellowship, and we were fortunate to recruit her back. And she's been engaged with the residency program for some time, and has perhaps the best personality in the department, and has ever since she was a resident. I don't think she's ever had a bad day, and even when she does, you wouldn't know it. And so she's been somebody who has always been engaged with the residency program, and somebody who really has been a great addition to the program administration. Dr. Perez is one of our associate programmers, specifically focused in two areas. One, she runs the curriculum for simulation. And her interests, clinical interests, are hernia and robotics for hernia. And so that's been a nice dovetail for her running the simulation portion of the residency curriculum. And then two, she's been focused on recruitment from the perspective of diversity. She is a member of our diversity committee and leads that group in identifying candidates to interview with our program. And she's made a huge effort and impact on that since we launched that initiative last year, and I will touch on that later on. So we are a 5-year training program. We are not a compulsory research program. We certainly encourage residents to pursue academic endeavors. We want to have people who have interests in careers as scientists in addition to surgeons, but we don't mandate it. And so it is something that we work hard to shepherd and mentor, but not something that we compel people to do. We take 7 categorical residents a year. That was a change for us 3 years ago. This will be our 4th year, 5th year actually, taking 7 in the match. Excuse me. And I mentioned the research time. On average, about half of the residents pursue that. Our residents go out after the PGY 3 year, which gives us an opportunity to help people shepherd ideas and develop research goals, find mentors, and then hit the ground running for those years. It also gives people a little bit of an idea of things that they really are interested in pursuing. So the primary goals of the clinical program are listed below, but really we want to create independent surgeons both in and out of the operating room, people who are leaders, whether they're leaders in their hospital, their communities. We want to identify people who are going to be leaders. Roughly outlined the goals of the training program here, based on PGY year, are as shown, and I won't read them. And in effect, they are progression from developing patient management skills to becoming independent in the operating room, being a teaching assistant. In general, what I tell most folks is that I expect by the end of PGY 1 year, people have developed some basic operative skills. And from a patient management perspective, they have become comfortable managing patients in the hospital with average postoperative problems and recognizing them and initiating care. I would hope that people are able to recognize patients who are becoming acutely ill or critically ill. I don't expect people to have advanced critical care skills by the end of PGY 1 year. That comes in PGY 2. By the end of PGY 2 years, should be comfortable in the ICU, should be comfortable managing patients independently. And then PGY 3 and 4 are the big transitions in operative skills. And then PGY 5 is listed below. So just to walk through a little bit what things look like from a service structure, our rotations for PGY 1s are 1 month. It's a mix of general surgery and subspecialty rotations. Our categorical residents do spend 1 month at Wake Med. As I mentioned, that's our educational partner in Raleigh. That is an excellent rotation for PGY 1s. You get some operative experience, perhaps more so than in other ways. And that's a commute. I didn't mention that earlier, but Raleigh is about 25 to 30 minutes from here without traffic. Reality is the hours that residents are traveling, there isn't usually a lot of traffic. And everything else is here. So we don't rotate anywhere else. And that's something that makes us not unique, but certainly different from some other similarly sized programs. You spend roughly 6 months over the course of your residency program at Wake Med, and then everything else is here, save 1 rotation at Hillsborough Hospital, which is part of UNC. It's a satellite campus about 10 miles away. PGY 2, the rotations get a little bit longer. And you can see those listed here. I mentioned Hillsborough Hospital. That's general surgery with some minimally invasive and robotic surgery. We send a PGY 2 resident there, and at present, that's the only surgical resident there. And then a Wake Med rotation, and you can see some of the specialty rotations. We do have a ICU day and night rotation PGY 2 years, so that's our only kind of night float rotation in the PGY 2 years. So we keep a second year resident in the ICU at all times, and that's a foundational learning experience. You have the opportunity, you're the only one there. You have the opportunity to really kind of grow, and that's a stretch rotation, and every year of training has some of those. PGY 3, we spend a lot of time at Wake Med. Surgical oncology rotation that primarily focuses on endocrine surgery, and then pediatrics. Transplants a PGY 3 rotation for us, and then we switched things around this year. We used to have PGY 4 vascular rotation, now PGY 3. And that fits better in conjunction with other training programs and really training goals with what a general surgery resident should do from a vascular surgery perspective. PGY 4 and PGY 5, the rotations get a little bit longer. We do have a senior in-house rotation that is our night float rotation, so that's a PGY 4 rotation. We do endoscopy as a PGY 4, that's a block of time, and then a mix of general surgery, specialties and subspecialties, minimally invasive surgery, oncology, which really focuses on colorectal, trauma and acute care, and then Wake Med, which again is acute care surgery, and it is a trauma hospital. They're a level 1 trauma center. They're busier a trauma hospital than we are, and so that's basically a chief resident rotation at Wake Med in the PGY 4 year. And then PGY 5 is, as you see here, we do have an elective in the PGY 5 year, and so we have thought of that as an opportunity for residents to reach their goal for whatever they're going into and be able to spend some time doing that. So that's been used for thoracic, extra rotation for pediatric surgery, including sometimes going to Wake Med for that. Additional growth and development in things like plastic surgery. So lots of opportunities in that elective time, but the rest of the time is developed in really focusing growth and independence in complex operative skills. Let me touch on what in-house call looks like for us. So approximately one night a week for the PGY1s, and depends on the rotation and depends on the schedule. There are heavy vacation months in the spring and fall, and sometimes people end up having 2 nights in a week. But we are a 24-hour call, and we have been for a long time. We've had mixes with weeks of night float. We've talked about going back to that. We've talked about trying to find ways to have a night float rotation of a month long. That doesn't work out very well. The math doesn't work out very well relative to all the other PGY1s who rotate with us. So we have continued as a night float rotation. I'm sorry, night float rotation only in the PGY2 year for the ICU, as I mentioned earlier, but the rest of the calls, both in the PGY1 and PGY2 year, are 24 hours. In addition to that ICU night float rotation in the PGY2 year, we have what we refer to as a junior in-house. That's the person who helps see the consults, does some operating. And so we have 2 PGY2s in the house at night. One is that ICU person and the other is the junior in-house, and that's the 24-hour call shift. And then at Wake Med, you average roughly every 4th. There is a night float system there. We've gone back and forth with that, but the residents have preferred having that system at Wake Med, and so that is a weekly basis. And same thing with PGY4 is there's the time at Wake Med. We do have the night float rotation as the senior in-house. And then when you're on some of the other services like surgical oncology, the acute care surgery service, you have 1 or 2 half days a month on a weekend where you're the senior in-house. So you may have Saturday 12-hour shift, or Friday night 12-hour shift. So those things happen in the PGY4 year as they do in the PGY5 year. So there is no night float rotation. There's just the 12-hour shifts that the PGY4s and 5s cover outside of those. Let me just touch on attrition. We've been fortunate over the last decade plus that we have not had any attrition. If you look over a 20-year period, we're pretty much right at around the national average, about 10% attrition. That, I guess the national average remains in closer to 15% than 10%, but it's in that ballpark. But we've been fortunate the last decade plus that we have not had anybody depart our program or our department. And we're very pleased and very proud of that. And I think that is a testament to the faculty. I'm often asked what are the things that stand out about our program or make our program unique. And I don't know that there's anything that is absolutely unique, but I always highlight the resident-faculty relationship. It has been collaborative between residents of all levels and faculty. Residents and faculty get to know each other. They talk to each other. The faculty are approachable. And that's across now 3 chairs that I have been the residency director for. And I really think it's an institutional paradigm, and it's across disciplines as well. And so it is, I think, a nice place to work. There's certainly a hierarchy as there is in medicine in general, but I think it's collaborative. And that's across years, residents, because they get to work with each other so much, you get to see each other so much, being at one site, really get to know each other. And so they develop friendships across PGY years, in addition to the deep friendships that you develop within your PGY year. And as I said, faculty as well. I'll talk about the operative experience, and then I'll take a pause and I'll record the second half independently. So we have had forever a robust surgical experience here. This is just the last 5 years, including this last graduating class. You'll see there is a drop in the last graduating class from what was previously an average of around 1,100 cases to around 1,000 or just over 1,000. And it really is COVID driven. When I look at this, there was slightly fewer cases performed by those residents in their PGY5 year, which was impacted, but their PGY4 year was fairly heavily impacted. And so that was the biggest change that I saw. when I look through the numbers, but still a fairly robust operative experience and across PGY years. Our PGY 1 residents certainly get to the operating room and have some experience that ramps up PGY 2 year, and then PGY 3, 4, and 5 year very heavy operative experiences. And then this is just what this numbers look like for the chief cases. So the green line just represents the RRC minimum of 200 cases in the chief year, which is a PGY 5 year basically. And last year's chiefs were about the same as every prior year, in that 275-ish range. So that's why I say last year's graduating class had a lower numbers as a whole, but also similar PGY 5 numbers. So this was mostly their PGY 4 year that was a change. And then if you look at the subspecialty cases, so these are some of the categories for case volume, and you can look at the dark blue are the minimums, and then the light blue are the bigger numbers. We're not a huge liver and pancreas place. People get twice what there's the minimums, but it's not gigantic. But where we really thrive are alimentary tract and abdominal cases. The others are certainly robust experiences, for instance, thoracic peds, laparoscopic basic and complex we do a lot of, but I would say our strength has been for quite some time and continues to be abdominal and alimentary tract surgery for the general surgery training program. And I don't see that changing. The other aspect of things is beyond just what number of cases you're doing, it's what you're doing when you're doing a case. And that is something that I think we've done as well as anybody else, and that has evolved. I mean, there's no getting around it. It's different than it was 15 years ago at every training program. There's not the same level of independence for a variety of reasons, but I think we've managed that as effectively as every other program. And we have a committed number of faculty, many of who've been here a long time, who want to have that people grow toward that independence and give people those opportunities to do that, and help them achieve those independence in the operating goals. So I'm going to stop there, and I'm going to stop my screen first, and then I'll record the rest separately. And again, thanks for watching, thanks for listening, and thanks in particular for jotting down questions that you might have that I don't cover in these comments. Thanks.